Welcome to Promoting Patient Choice in the Advancing Kidney Health Initiative with Dr. Lou Diamond and Rob Blaser. I'm Sherry Sliwa with the Coalition for Supportive Care of Kidney Patients. Before we begin, just a few housekeeping items. We've muted all attendees. We encourage questions throughout the webinar and ask that you use the chat feature on the right-hand side of your screen to submit questions. Type your comments in the text box, choose all participants, and press enter. We will attempt to answer all questions during the presentation, as we may not have time for questions at the end of today's presentation. At the end of the webinar, as you close your webinar screen, you should receive a pop-up evaluation. Please fill that out, as we greatly value your feedback. And our webinar will be recorded today and available on our website, kidneysupportivecare.org, in a few weeks. Dr. Dale Lupu, if she can sign on, will serve as our moderator. If not, it'll be Dr. Moss. And I do not have his bio in front of me, but he is on the chair of the Coalition for Supportive Care of Kidney Patients. He is a physician nephrologist over at West Virginia University. He's also co-principal investigator on the Pathways Project, a more funded foundation grant project to integrate supportive care into the treatment of patients with advanced CKD and ESKD. Go ahead and introduce our presenters. Diamond is a nephrologist with interest in quality measurement and improvement, HIT, health system reform. He serves on the executive committee for the Coalition for Supportive Care of Kidney Patients, as a delegate for the Renal Physicians Association to the American Medical Association House of Delegates, and as a board member for Quality Insights Holding. Previously, Dr. Diamond served as the Robert Wood Johnson Health Policy Fellow, Vice President Medical Director, Reuters Healthcare, Professor of Medicine, Chair at Georgetown Department of Medicine, and Dean for Clinical Affairs at DC General Hospital. Presenter Rob Blaser has served as Renal Physician Association's Director of Policy since October 2003. Previously as RPA's Director of Federal Affairs and Regulatory Analyst. Among Rob's primary areas of responsibility since joining RPA is the management of RPA's legislative and regulatory portfolios and policy development for the organization. In this latter role, Rob has taken the lead in drafting over 30 position papers for RPA, has also developed expertise in diverse areas as legislative developments affecting renal care, physician reimbursement in the Medicare fee schedule, and other issues pertaining to CKD-specific coverage and reimbursement issues. Rob is also Program Director for RPA's Political Action Committee.
So really, there were 3 points for us to remember about the coalition, and clearly Rob is going to be making points as well. But our concerns are that patients with kidney disease die poorly compared to other chronic disease populations, such as cancer, heart failure, dementia. And palliative care can improve goal concordant care for patients with kidney disease, so patients can exercise their choice and actually receive the treatment that they want. But there are policy changes that are needed to improve access to palliative care and to improve goal concordant care for patients with kidney disease. Next slide. So you already had the introductions. These are the disclosures. Next. So the objectives for this webinar are to explain the unmet needs for supportive care in general and for kidney disease patients in particular, to describe the Coalition for Supportive Care of Kidney Patients, including its current initiatives, to review the basics of the Advancing American Kidney Health Initiative and its patient choice elements, including Rob, its non-elements, and discuss public policy challenges to improve care of patients with kidney disease. Next. Lou, you chime in when you regain your sound. So what is the context? The context is that more seriously ill U.S. patients are started on dialysis than in other countries like Canada, UK, and Australia. There's an absence of a medical management without dialysis alternative that's well funded in the American system. There are small efforts being made in various places. Palliative care is rarely utilized. Shared decision-making is poorly integrated into care. Advanced care planning is not systematically done. Patient symptoms are undertreated. Quality of life suffers as a result. And unfortunately, at the end of life, end-stage renal disease patients receive unwanted high-intensive care. This is reflected by high in-hospital death rates, low and late referral to hospice, and families. When asked through the Family Bereaved Survey, families rate end-of-life care worse for patients on dialysis than for patients with other chronic conditions. So the concern is that quality is low, and clearly innovation is needed. Next slide. So the Coalition for Supportive Care of Kidney Patients was started by the ESRD network in 2003. Its mission is to promote effective interchange among patients, families, healthcare professionals, and payers to ensure the provision of patient-centered supportive care for patients with kidney disease. And the goal is to create culture change that transforms the treatment with kidney disease, putting every patient at the center and integrating palliative care principles and practices throughout the care continuum. Next slide. So the Coalition's strategic plan is to support and participate in research and disseminate findings. We have several major research projects going on right now. To educate about the need for kidney supportive care, as we are doing in this and other webinars and a series that we have running in Nephrology News and Issues. To drive quality improvement, to refine and modify governance, to pursue financial sustainability for the Coalition, to provide membership services and products, to identify marketing and branding activities, to develop partnerships and alliance. We're grateful that the Renal Physicians Association is participating with us on this webinar, and to conduct advocacy for patients with kidney disease. Next slide. So the present Coalition initiatives are the Pathways Project funded by the Gordon and Betty Moore Foundation, in which 14 evidence-based best practices were developed using a systematic literature review and input from a technical expert panel. We're now working with 11 dialysis centers and 3 chronic kidney disease clinics to implement 3 of the 14 best practices. The My Way Project, which is research on how to implement advanced care planning in chronic kidney disease clinics. The webinars I mentioned, the Nephrology News and Issues series I mentioned. We are in the process of finalizing the chapters for a book to come out next year by Oxford University Press on integrating palliative care into nephrology. We maintain a website, and we conduct membership stakeholder needs surveys. We're organizing a luncheon at the ASN Kidney Week in just a month. Next slide. So the current state of palliative care in the U.S. This is the big picture. Palliative care is for specialized medical care for people with serious illness. It focuses on providing patients with relief from the symptoms, pain, and stress of a serious illness. The goal is to improve the quality of life for both the patient and the family. It's appropriate at any stage and at any age and any stage in a serious illness, and it's provided along with regular disease treatment. And when we did some focus groups of kidney patients and nephrologists, they preferred the term supportive care to palliative care, and that's the reason why we're the Coalition for Supportive Care of Kidney Patients. And in fact, the Kidney Disease Improving Global Outcomes, when it did a controversies conference, it was a conference on supportive care for patients with kidney disease. Next slide. The definition of a serious illness is one that carries a high risk of death over the course of a year and has a strong negative impact on patients' quality of life, including their function, or is highly burdensome to patients and their families. And the Pathways Project is really an initiative to improve care for seriously ill patients with kidney disease. Next slide. 20% of our CKD and ESRD patients are seriously ill. So why do organizations need palliative care? Really, the concentration of risk for poor quality and spending lies in a small subset of patients. There's strong evidence that palliative care improves quality and satisfaction and decreases cost. And there are very few strategies that simultaneously improve quality and reduce spending. Next slide. So this is from the Center to Advance Palliative Care. This is not specific only for patients with kidney disease, but palliative care drives a positive patient experience, improves quality of life, decreases symptom burden, reduces symptom distress by 66% in the last months of life, drives high satisfaction, positive patient experiences. 93% of people who receive palliative care are likely to recommend it to others. Next slide. Palliative care also improves cost effectiveness. This is again from CAPC, or the Center to Advance Palliative Care. It results in a 48% decrease in readmissions, decreases the cost per day by 28% for inpatients. For outpatients, decreases admissions by 50%, decreases emergency department visits by 35%. Skilled nursing facilities, there's a 43% in hospital and emergency department transfers at the end of life. And in home-based care, there's a 36% decrease in total cost. Next slide. Well, we told you that palliative care, and there are many unmet palliative care needs for patients with dialysis. Here are some of the reasons. The goal of palliative care for patients with kidney disease is to achieve patient-centered, value-based care. Palliative care is virtually non-existent in care of patients with kidney disease. If a dialysis patient under the Medicare benefit is admitted to the hospital for more than 2 days, less than 1% of them will receive a palliative care consultation, even though the in-hospital mortality is over 20%. For patients with acute kidney injury requiring dialysis in the hospital, and this patient population had a 28% mortality, only 8% received palliative care consultation. So in the hospital setting for both end-stage disease and acute kidney injury, palliative care consultation is very slim. Not much going on, but yet a high mortality for patients with kidney disease in the hospital with these conditions. Next slide. So what can we draw from this? This is this article by Chetier that was in CJASN last year. Patients who died during the hospitalization had a 21% shorter length of stay and 14% lower costs if they received palliative care consultation. For patients who were discharged alive, there was no difference in the hospital length of stay, and the costs were actually 11% higher, but the post-discharge outcomes were better. In the 30-day post-discharge period, patients who had received inpatient palliative care had a higher likelihood of hospice enrollment. That hazard ratio was 8 times greater, and a lower likelihood of rehospitalization. Both of those were statistically significant. Next slide. So these are the dialysis organizations participating in the Pathways Project: American Renal Associates, Rogerson Institute, Atlantic Dialysis Management, and the VA Medical Center in Washington, D.C. Next slide. And this is the Pathways Project Change Package, the 14 evidence-based best practices that were developed as a result of the literature review and the technical expert panel. It's using the Institute for Healthcare Improvement Collaborative Breakthrough Model to try and really have the 14 different sites participating share what they've learned in terms of innovations to improve supportive care for patients with kidney disease. And we actually are getting together in Washington, D.C. Next week as the second time to share the progress that's been made. Next slide. So what's new and different about the Pathways Project? Well, in it, we are intentionally identifying seriously ill patients with chronic kidney disease and end-stage renal disease. We're intentionally engaging them in conversation about their values and wishes. And as part of that, we've been providing communication skills training for the physicians, nurses, social workers, administrators working in these chronic kidney disease clinics and dialysis centers. We're offering options including palliative dialysis and medical management without dialysis. And we're teaching skills and providing tools and resources to the kidney care providers so that they feel better equipped to provide supportive care to their patients. And then, of course, what we're doing is we're collecting data to document the difference that this innovation is making in the care of patients with kidney disease. Next slide. And what we're measuring hospitalizations, emergency department visits, offering a palliative dialysis, discontinuation of dialysis, hospice admissions, where dialysis patients die. Next slide. And then, Rob, I'm going to turn it over to you at this point. Hopefully I set this up so that you can sort of talk about what's being offered and what's not being offered with the ETC model.
Okay, I'm happy to, and everyone can hear me, is that right?
Yes.
Okay, good. Thank you, Woody. All right, so I'll be presenting on the Advancing American Kidney Health Initiative. Next slide, please. So quick overview, we'll talk about the goals of the initiative, what was in the executive order, which was kind of the underlying document that, that got signed on July 10th, the ETC model, the two voluntary models that I think might have a application for supportive care, and then what a lot of people in Washington think about the initiative and what the outlook for it is. So next slide. So the primary goals were to reduce the number of Americans developing ESRD by 25% by 2030. So this would be the CKD care processes that are probably more encompassed in the voluntary models. The 80% of new ESRD patients in 2025 will either start at home or start with the transplant. And this goal is the subject of some controversy. I think even the organizations that are most supportive of the initiative overall think that 80% might be a little ambitious, and maybe a number like 50 or 60% might be more realistic. But I guess if you shoot for the stars, you get the moon, and that's probably what the administration is thinking about here. And then doubling the number of organs available transplant by 2030, and they seek to do this through a couple of different ways, which I'll talk about in a second. Next slide. So in the executive order, it presented as official U.S. policy the following three objectives: prevention of kidney failure whenever possible through better diagnosis, treatment, and incentives for preventive care. And of course, this is the CKD part. Increasing patient choice through affordable alternative treatments for ESRD by encouraging higher value care, educating patients on treatment alternatives, and encouraging the development of artificial kidneys. And this is where the focus on home dialysis comes in. And then increasing access to kidney transplants by modernizing the organ recovery and transplant systems and updating outmoded and counterproductive regulations. An important thing to remember is this doesn't necessarily have the power of the rule of law. Not all executive orders are created equal. But I think the idea is this is a little bit more of a work plan or a thematic blueprint for improving kidney care rather than something that's like an actual piece of legislation. So next slide. So specifically, what does the executive order call for? It calls for an awareness initiative on kidney disease and related diseases, and that should be out sometime in about a month or so. A payment model to identify and treat at-risk populations earlier in disease development. These are the requests for applications that were promised by the end of the summertime but had not been released yet. I was thinking they might be happening last week, and it could be that they could happen any time now, but they haven't come out as of today. The payment model to increase the home dialysis and kidney transplants, and this is the proposed ESRD treatment choices rule that I'll go into a lot of detail in a moment. Encouraging the development of artificial kidney, and CMS is supposed to put out some sort of paper or regulation on how they would propose to do this within about a month. Increasing the utilization of available organs, again within about a month. And then supporting living organ donations, time frame unspecified, and I think this really takes the form of providing some financial assistance to living organ donors to address things like having to stop work or travel expenses or that sort of thing. Next slide. So what is in the ESRD treatment choices model? And this is the proposed rule that came out July 10th, which is the same day as the big signing ceremony that happened in Washington. But it's mandatory for a randomly selected 50% of the U.S. based on geographic designations known as hospital referral regions that came out of, I don't know if it's the Dartmouth Atlas or some other research at Dartmouth, but a Dartmouth project came up with the hospital referral regions that have been used in some other contexts in both the private and public insurance spaces. Nephrologists who are described in the rule as clinicians and dialysis facilities are included. It utilizes upside-only payment bonuses in years 1 to 3 of 3%, 2%, and 1%, which is known as the home dialysis payment adjustment. So no penalty there. You just strictly get a bonus for however many patients, according to the way that they have it set up, that you have receiving home dialysis. And then there are upside and downside payment adjustments, so bonuses and penalties for both home dialysis and transplant metrics known as the performance payment adjustment part of the rule. Some of the things that are areas of concern is that the PPA is asymmetrical So throughout the period of the program, the penalties are higher than the bonuses, and this has given a lot of people a lot of pause, because that means that in any year you're going to have north of 50% of participants taking a penalty rather than getting a bonus. So folks think that's kind of unfair. The penalties are significant. They begin at 6% and 7% for nephrologists, and 13% for facilities. And I think the idea is here is they probably could have incented behavior with penalties that weren't, in excess of double digits by the time the program's over, so they probably didn't need to go there. But anyway, and then exclusions are limited and the metrics are somewhat untested. Next slide, please. So for the two RFAs that we haven't seen yet, but were also announced on July 10th, but kind of only in the broad outlines, not actually having the request for application themselves. The first one is the Kidney Care First model. It's for nephrologists and nephrology practices only. It does include CKD care stages in 4 and 5 and dialysis. It establishes a capitated payment for CKD in addition to the current monthly ESRD dialysis. They call it a monthly capitated payment. That's what MCP stands for. So the CKD payment would be quarterly and expected to be about $240 for a quarter's period, so it's somewhere around $80 a month. But you would not be able to bill for the normal evaluation and management codes, the office visit codes, established or new patient office visit codes that you typically could bill for a CKD patient. The MCP, the dialysis MCP, would be set at the current 2 to 3 visit level code, which, if folks unfamiliar with the MCP, there's 3 levels of payment. There's one for 4 or more visits, there's one for 2 to 3 visits, and there's one for 1 visit. So this would set the payment at the mid-level setting. However, the visit structure would be waived. I believe we haven't seen the RFA yet, but I believe you'd only have to see the patient once in the month to get what is currently the 2 to 3 visit level service. So, they're given a little bit on that. It would qualify as what's known as an advanced alternate payment model in 2021, which would relieve participating nephrologists and nephrology practices from their MIPS requirements and would give them the presumed 5% bonus eligibility, although I've heard that there's been some holdup in paying the 5% bonuses on previous AAPM, so we'll have to see how that plays out. Payments would be adjusted up or down based on quality, performance, and very interestingly, you could get a transplant bonus of up to $15,000. That's not a misprint per new patient getting transplanted. And the way it would play out is they'd have to be the transplant would have to work for 3 years, and you would get $2,500 for the first year, $5,000 for the second year, and $7,500 for the third year, for a $15,000 total for the bonus if the transplant, if the patient were able to survive with the transplant for 3 years. Next slide, please. So the other one of the voluntary models was the comprehensive kidney care contracting model. Again, we're still waiting on the RFA. And this also has requires the transplant centers participate in the model, along with nephrologists, and dialysis facilities are optional. And this is interesting. The ESCO models, that was kind of the renal ACOs that CMS is still running, and the proposed legislation that was talking about trying to establish some payment models in ESRD all require dialysis facilities to participate. And in both of these two voluntary models, they can't participate in the first one, the Kidney Care First, and they're optional for the second one, so that's kind of a significant difference. It sets up 3 different models differentiated by risk. There's a graduated model where there's no risk, a professional model where there's 50% risk, and a global model where there's full risk. This also includes the provisions that were the features that were included in the Kidney Care First model, the CKD care, and the transplant bonuses. And both the global and the professional models would be AAPMs, and since the graduated models don't take on any risks, they wouldn't initially be considered AAPMs, but I think if they moved on in later years and took risks, they could be considered AAPMs. Next slide, please. So what is the Washington perspective on all this? With the RFAs as yet unseen, the ETC is much less popular than the voluntary models. In preparing this series of slides, I looked up Miles' Law, which says where you stand depends on where you sit. That comes from English parliamentary procedure of the 1800s, according to Wikipedia. I just wondered where they came up with that. But it applies here because, it depends on where you're at in the kidney stakeholder community about how you feel about this. And I think everyone has concerns because the proposed rule has some fairly significant policy holes. But, to the extent that you think the whole thing should be gutted or whether you think that there's a lot to work here with and it just needs to be refined sort of depends on your position. The nonprofit kidney groups have identified areas that must be addressed, but they really want to do their best to be supportive philosophically. The transplant organizations are concerned, but they might have other fish to fry. Again, they're supposed to be doing proposed rules on the organ procurement organizations that I think might have more meaning for them in their daily lives than these models do necessarily. And then among industry groups, the dialysis organizations are adamantly opposed. And other groups associated with home dialysis are generally supportive, and for what it's worth, pharma either opposes or sits this one out. They don't have that much of a dog in this hunt. However, there are, I think it's Bio, if I'm not mistaken, which is a trade organization for a lot of the pharma community. They don't like mandatory models, period. So that's why they would have a problem with the ETC. The external groups that have weighed in on this are opposed mostly on methodological grounds. MedPAC, which is the Medicare Payment Advisory Commission, that's the advisory body to Congress on Medicare payment issues, they really came out with a pretty remarkable comment that said, do not implement this model, period, which is kind of striking that one government advisory body would say that about another government agency's proposal, but they just kind of felt like there were too many profound methodological gaps in this for this to go forward. I can tell you that the AMA came out and said that that CMS should not implement the performance payment adjustment part. That's the bonus and penalty aspect of it that I spoke about on a previous slide. Some people would say if you're not doing that, then you really don't have a model at all. So, if you're not implementing the PPA, you might as well not implement the whole thing. But those are two external groups that have weighed in as well. So, long story short, there's a whole lot of concern in the kidney and policy communities about the ETC model. Next slide. So what are the pros of the ETC? It's very ambitious, and I think a lot of people would say it sets the correct priorities in terms of, trying to promote home dialysis. Of course, the U.S. is way beyond the rest of the industrialized world in home dialysis rates. I hope I'm not speaking too glibly there, but I'm pretty sure that's the general consensus. And that we should be promoting transplantation as well because that's a gold standard for renal replacement therapy. So what are the cons? Of course, there's significant methodological concerns. The scope might not be manageable. I mean, 50% of the whole country is a pretty big deal. And CMS says in the proposed rule that they're only doing 50% to make sure that the data that they get on transplant is robust enough because the numbers are so small for transplant that to actually do a methodology on something, you need 50% of the country participating in it. A lot of people, and I can tell you RPA was in this boat that said that's not a good enough reason to subject 50% of the country to this. And, there's this whole thought process that it ceases to be a demonstration project if you're forcing half of the country to do it. So, but anyway, so there's concerns with scope. It's not really holistic. This is something that MedPAC said. There's nothing having to do with CKD in the ESRD treatment choices model, so that's a bit of a concern. As I noted before, asymmetrical bonus and penalty proposals probably over punitive for everyone who's involved. And there's some concerns that patient choice could be inadvertently harmed. There's going to be such significant incentives for the clinicians and the dialysis facilities to try to get patients to take up home dialysis, maybe patients who don't want to try home dialysis or don't want to do it or might not be good candidates for that. So there's some idea that, and paradoxically, CMS could be harming patient choice by creating such profound incentives for people to choose home dialysis. Next slide. So for the Kidney Care First and the CKCC models, the pros are that CKD is addressed. There are those very meaningful transplant bonuses that we discussed before. They're a little bit closer to the ESCO programs, and if folks don't know what those are, that's the ESRD Seamless Care organizations. Those, again, are the renal ACO type models that have been in place for a couple years now. Been a lot of lesson learned from that because there's a good, I think it ended up being close to 13 to 15% of the country, of the country's patients were in ESCOs, if I'm not mistaken. So they're fairly rich data that can be gathered through that, so that it's easy to build on those lessons. You would be eligible, participants would be eligible to be in payment models, and they're very nephrologist-centric. So that's a pro, of course, from RPA's perspective, because we're a nephrology organization, but we think it's a good thing. In terms of the cons, there's some thought that the CKD bonus might be insufficient to incent change, and then unclear attribution, exclusions, and denominators might have a chilling effect on participation. Next slide. So what's the outlook for this? Despite the positive consensus on the boldness and the priorities of the ETC, there are concerns that it's the SGR for dialysis. SGR going back in the old days, this changed probably about 7 years ago, but there was something called the sustainable growth rate, which is the way that Medicare Part B providers, mostly physicians, got paid by Medicare. In the first couple of years, it ended up in positive numbers for Part B providers, so it was a good thing. But then for the next probably 10 years, it resulted in proposed 10 to 20% payment cuts. Actually, probably 5 to 20% payment cuts. And so organized medicine had to go to Capitol Hill every year and say, you can't do this. The Hill had to pass a bill and say, we're not going to do it. So it ended up that there were year after year significant payment cuts proposed for a large sector of Medicare. A lot of people were worried about that's going to apply to dialysis as well with the ETC model. So that's resulted, of course, in significant opposition to it from both within the kidney space and externally. There is some talk that the ETC might be subject to legal challenge depending on what's in the final rule. I think there's some thought that the fact that, again, as I noted before, that it's 50% of the country, it's really not a demonstration project anymore, so that might be what the basis for the legal challenge would be. The voluntary models appear to have much more support broadly. In terms of the whole ball of wax, CMS solicited comment on whether there should be, whether they should delay implementation until April 1st, 2020. I think that seems almost certain, and I wouldn't be shocked if they went beyond that, just because there are so many methodological concerns moving forward that they probably have to do that. And presumably we're going to be seeing much more rulemaking on all of these models later in the fall, so much more news to come on this. Next slide. Okay, and there's my contact information. I really appreciate the opportunity to present on this. Thank you. Thank you, Woody. Thank you, Dale. Thank you, Sherry.
Sure.
Thank you, Lou.
All right, so don't go away, Rob. So we want everybody who's now an attendee and is on the internet to, if you have questions, type them in the chat function, and we will go ahead and ask them. So Rob, let me start out though by asking you. You could be optimistic and you could say this is a real move towards value-based care, home dialysis, transplant. You sort of alluded to that. This is giving patients a better quality of life. Or you could be skeptical and you could say, well, this is really coming to fore because Alex Azar is cabinet secretary of DHHS and Adam Bowler knows a lot about home health. And so that's just, something that their pension, something they would want to do. Do you think this is a real move more in the direction of value-based care for patients with kidney disease?
Well, I think it is, Woody. I guess, if you were to go to the cynical side of this, I believe there's something in the rule that talks about the amount of money that would be saved by Medicare, and it looks like I want to say it's like $150 million over a fairly brief period of time. So that's money coming out of the ESRD, of the kidney care community going back to Medicare. So I think some people would say if you're taking money out of the system, that can't be good. So you might be getting more value, but the value is accruing back to Medicare. In fairness to Medicare, they're supposed to be, being efficient stewards of the Medicare dollar. So, or CMS, in fairness to CMS, but you could definitely look at it both ways. Again, can't argue with the priorities they picked. I think the rulemaking has some fairly massive gaps that they have to address. Did I answer your question?
Yeah, no, you did. Dale, do you want to ask a question?
Yeah, Rob, so do you, from the perspective of the coalition and our concern about having the full menu of choices for patients who are what we call seriously ill, do you think that it's a good thing for us to be kind of hooking on to this notion of patient choice and saying that's good, but what about the choices that people need who really aren't going to benefit from home dialysis, really can't do it and can't do transplant? There are these other choices that we're saying ought to be part of the menu. Is that a viable message, and is anyone going to listen to that?
I think that's the exact space that you all should be in, and I would say that some of the information on the earlier slides about the potential savings through more effective use of supportive care, more cost effective. There's money to be saved there if they did it right, and you don't always want to look at it in dollars and cents. Of course, we're trying to improve, patients' lives at the end of life, but I think that's the exact space for you all to be in. The ETC model was disappointing to me in the fact that they didn't tip their cap at all to palliative care. I would think that the voluntary models might be more the playing field because that's where CKD is more addressed. And I think CKD, the whole idea that you want to catch patients before they start dialysis, so it wouldn't necessarily apply to, say, ETC. But I think you all are pretty well positioned to make a solid argument for this, and you've definitely got some good points to make.
Mm-hmm. Well, and the other thing that concerned us in the ETC regulations was a very prominent discussion about what they called lemon dropping. And
right.
So for folks who haven't had the pleasure of reading all 200 pages or whatever it was in the proposed rule, there was discussion of both what I think is more familiarly known as cherry picking. In other words, the idea that let's say a nephrology practice might really go out and look for patients, particularly who are good transplant candidates, right? Like do something to attract those candidates because those are the cherries and they would be financially available. But they also talked about lemon dropping, which in my view would be exactly the patients we're talking about who need something different. And it was a very punitive discussion around lemon dropping. Can you comment on that at all?
Well, I guess if you want to give them any credit on this, you can say at least they're cognizant of it. There's been times that policies come out where they don't even consider it cherry picking or lemon dropping. So to the extent they're discussing it is good. I agree with you, though, that I thought it was punitive, and it seems as if, this is another one of the policy holes that's in the proposed rule, at least, that they didn't really give much thought to ways to prevent that, particularly for folks who would be represented by the coalition. So, no, I couldn't agree with you more. That I don't think that they I don't think they gave appropriate attention to that. And I know that you all submitted comments on this, and from your mouths to God's ears, hopefully that they get reflected in the final rule.
Right. Thank you. So do you have from your perspective for so long working with members of RPA, so we've got this, little intrepid group of people that's a mix of all disciplines, patients, some as well, part of the coalition, members of the coalition, and I'm not sure who all's on the call, but what advice do you have for being effective advocates, just for our members who are on the call?
I wonder whether the coalition should try and get more involved in other coalitions. And it might not be part of the mission, and maybe you don't want to do that. But, for instance, there's this Kidney Care Partners group, and they might have a lot of there might be reasons the coalition doesn't want to join Kidney Care Partners, and I would understand that. But they are a group that has a lot of visibility in Kidney Policy Washington. So maybe that's a thought. I think you guys have a tremendous story to tell, And it's not the way it was 10 years ago when the whole death panels conversation came up and no one wanted to talk about it. I can tell you that even in Republican policy circles, people that might not look at something like this, that conversation's been turned around and people get the whole idea of advanced care planning and advanced directives. And therefore, I think the ground is a lot more fertile than it might have been in previous eras. So you got a great story to tell, and I think you've got a more receptive, presumably more receptive audiences on this. Of course, it's something you got to thread the needle on because there are some people who might not get supportive care and might fall back on old erroneous positions about why you should go there. But I don't know if that's good advice or not, but I think got a story to tell, and it might just be figuring out the best ways to tell the story.
Right.
Dale, let me ask Rob another question. Rob, you commented about the 80% goal for home dialysis by 2025. If you recall, in their books, the Stanford Graduate School professors wrote about big, hairy, audacious goals, and it's a question of whether or not 80% is a BHAG, as they refer to it, or whether or not, as you well know, there are middle-income countries that have a peritoneal dialysis first policy. Thailand even is one of them. And so really, to everybody who can go home, they start with home dialysis. You sort of have a perspective on that. Obviously, the large dialysis organizations who have a lot of capital riding in dialysis centers wouldn't want to see that type of move. But do you see the industry? Do you see patients really wanting to have that option of trying it out at home first?
Well, I think patients obviously would do. I think just where the 80% goal seems to be based on in the proposed rule, CMS talks about Hong Kong and New Zealand and Australia and places like that. And I know the RPA take on that was international comparisons don't always hold up. They don't have ESRD program, and I'm kind of free associating here, so take it for what it's worth. But they don't have like an ESRD, mandatory ESRD program the way they do in the U.S., and there's a bunch of other reasons that kind of confound those comparisons. So, and as discussed, even the most optimistic organizations, and I'm thinking, for instance, of ASN here, they were saying, well, maybe 60%. 80% might just be too high, and maybe the idea is that if you set the goal that high, that becomes its own problem because people aren't able to attain it. Now that said, everyone who can go home should. And Woody, you're the clinician here, but I've learned more about what's the actual
peritoneal.
Well, I know peritoneal, but that's an offshoot of another word. That's the what is it, Willie? What do they call that part of the peritoneum or?
Yeah, the peritoneum, the peritoneal cavity. Is that what you're talking about?
Right, yeah. So I guess the exclusions that they had in the rule, a lot of people in the community had concerns with the exclusions that they had here. And that the goal might be easier to achieve if you had more robust exclusions. There are some people who just have problems with their peritoneum and therefore can't go PD, and that wasn't really discussed very much in the rule. We're in the process of giving CMMI a little bit more insight on what we think the exclusion should be because, we think there's a lot of the thinness of the exclusions are going to expose participants to, having a really big denominator when they shouldn't because there's some people who just aren't good candidates. But I guess to your original question, should everyone go home? I guess should it be a home first? I don't think you'd get any argument out of us. It's just make sure you do it in a thoughtful way that doesn't penalize people who are trying to help folks.
Right. Reasonable exclusions. People just simply don't want to do it. We shouldn't force people to go home who don't want to do it. But among those who don't turn it down, help them, assist them, support them, so that they can
Absolutely.
try and if they're successful at home. Let them have the convenience of being dialyzed at home.
And I'll also say on the transplant side, one of the things our PA brought up is what about the patients who the transplant centers refuse to list for whatever reason. One of our leaders was talking about a woman who he's put up for transplant listing either 2 or 3 times, and she's been rejected for the transplant for the list. I guess you tell me how it works. What? Sure, but she's been rejected a couple times, 2, 3 times. So the whole idea: are you going to include them in the denominator for transplant? Because it's nothing that the nephrologist can do about it. They're trying to get this person listed, and if the transplant center rejects them, we were saying they probably shouldn't be included in the denominator because the nephrologists are doing everything they can to get them listed. So
right. For some reason, they're deemed to be medically unsuitable, that the transplant center feels they would be too high of a surgical risk for one reason or another. Right, and those should be exclusions as well. So, in fact, if we let some prudent planners just tweak this a little bit, we could maybe end up with something that would be halfway decent. And
I really want to stress the fact, maybe my presentation came off more negatively than it should have, and I'm sorry for that, but I would say, reflecting what people in the community are saying about this, the overall goals are just outstanding and the right thing to do, but there's a whole lot of quote-unquote refinement that has to happen before that would occur. And again, you got a group like MedPAC that doesn't really even have a dog in the hunt, and they're saying, wow, you probably need to shelve this and go back to the drawing board. So, it's not just people who are self-interested that are saying that.
Right.
Yeah.
So, Rob, one of the participants commented, we all agree that there are many more patients that could be doing home dialysis, but our health system mandates patient choice, and CMS is going to have to address this issue if they want 80% of patients on PD. Thoughts about that
absolutely.
comment?
Well, it's not just 80% PD transplant and home hemo. Just to be clear, but no, that's. It's interesting to hear the dialysis companies come up with the conversation about patient choice. But in fairness to them, a lot of people said that, that there's a lot of people that aren't affiliated with dialysis companies said that too. We think that this is going to kind of counterintuitively, damage patient choice because there's going to be these massive incentives to move people home who might prefer to be in center for whatever reason, might not have the wherewithal. There was also the issue in terms of I guess you have to be able to keep a lot of supplies in your home. You have to have a caregiver, all those kind of things. And that might be something that falls along socioeconomic lines. There might be people who don't have the socioeconomic ability to do all that stuff. But then if you're creating incentives to where the system is trying to get clinicians and dialysis facilities to send some of those patients home, that becomes its own complication.
Right. But it does depend on how creative and innovative we want to be. I've heard that in Canada, they even have assistants who will go to a nursing home and assist a nursing home resident to stay in the nursing home and receive dialysis in the nursing home.
Yeah, and also, I have also heard about some company, I think, is talking about doing daily deliveries of supplies to patients who might not be able to store them. So I agree with you. There are innovative ways to get around these things that seem like they're roadblocks.
And yet some people really will prefer to have the professionals and have even what's seen as camaraderie and kind of development of support, family, at the dialysis center. There are some people who really, that is their choice. That's their preferred choice. We have a question or a comment from one of our listeners. By the way, some patients are excluded from Transplant Center of Excellence transplant centers due to lack of caregiver support. They typically don't allow one to hire a caregiver for surgery. Not everyone has family and friends willing to stay home from their job for the 30 days required to care for the transplanted patient. So again, we get into that's both socioeconomic, but just sort of family capacity. Yeah.
Yeah, absolutely the case. And there's also something that makes the RPA leadership seethe is the concept of the wallet biopsy. One of our doctors was talking, said one of their transplant candidates said, yeah, we're going to have like a bake sale to hopefully get enough money to prove to the transplant center that we can afford the immunosuppressive drugs or whatever the costs were. And our physician was like, what are you talking about bake sale? What do you mean? And they said, oh, the transplant center, said we have to have so much money in the bank before they'll consider us a candidate. And you can imagine where the health providers are on that, or where the nephrology community would be on that. So, that's another thing in addition to the caregiver piece, the fact that this quote-unquote wallet biopsy happens is exceptionally problematic.
Yeah.
So Rob, what should we watch for next? Is going to be the next thing that's going to indicate whether it's going to fly or not?
Well, again, I've talked to people at CMMI, talked to people in the community, and I would be shocked if we don't have the RFA, say, by ASN, which would be the first week in November. So that would give you an idea of, what kind of lessons they might have learned from the ETC rulemaking that they might be applying to the voluntary models. And I guess the next thing to look for is what happens with the rulemaking on the ETC. Does, one option would be for CMS to reopen the comment period. That's not unheard of. They could do that to say, we got sufficient comments on this that we think we need to get more input. That's not possible. They could say we're just delaying this until April 1st, and we're going to put out a final rule sometime in, say, December. That's going to hopefully address a lot of the input that we got from, from the community, and we're going to move forward with this. I was in a meeting where there was a representative of the administration there who said, "Oh, we are moving forward on this. Have no doubt that this is happening." I guess addressing the fact that there are people in the space that have said you need to draw back and redo the whole thing, this person did not infer that. They said, oh, we're moving forward on this. If I were to make a best guess, I would say that final thing where they put out a final rule somewhere in December and try to implement on April 1st happens. I think it would be prudent if they waited until July 1st and really did their best to address all the input that they're getting from the community. But there's a bunch of different reasons why policies move forward, and some are policy-based, and some are politically based, and some are otherwise based. And so, you probably got to account for all of the possibilities there in figuring out what they might do next.
Right.
Yeah. Well, one last question from me, Rob. The amount of money that is proposed for the quarterly CKD payment does not seem to me like giving much room to do comprehensive sort of medical management without dialysis programs, or really much room to move at all. What's your perspective on that proposed payment amount?
Well, we couldn't agree more. We were thinking, we, RPA, were hoping that CMS would make that number be pretty close to the monthly payments. So rather than $240 quarterly, $240 or somewhere in the ballpark of that. Maybe even $200 monthly, something like that. They came out with the $80 figure. Now, I will tell you, I've had conversations with people at CMS who have said, well, we base that on claims figures and how much E&M work was being provided to CKD patients. They can go through diagnoses and the E&M claims. They can do a claims-based calculation on it. And they said, oh, no, nephrologists would be making money on this because based on what they're billing now versus, what they would get out of this, whatever that, $80 a month works out to be, it's whatever, $960 a year. That's more than they're currently getting for their E&Ms that they're billing on CKD patients. Now, RPA has the different perspective, and we're the group that's at the RUC that looks at the practice expenses and the staff costs and everything to provide these kinds of services. We're saying, why don't you incent them to do it really well, hire up a couple staffers to bird dog these patients, make sure they get all their, diabetic or hypertension care and everything else they need to do. And even with that, I mean, if you keep people off of dialysis for 6 months, I mean, what's the savings there? The savings dwarfs the amount of money that CMS would be paying in that case. But in fairness to CMS, the oldest policy argument in Washington is, well, if you pay a little more now, you're going to save so much money later. Of course, we in kidney disease think we have the classic and, evidence-based argument for that. But in fairness to CMS, they're having to defend the federal dollar, and they've got everybody and their brother making that argument to them. So I hate to say in fairness, it makes my wife crazy when I say in fairness, but in fairness, they've got reasons that they might be skeptical of stuff like that. But we as an organization could not possibly agree with you more. We think the $80 is a woefully low number for what they're trying to make happen.
It's not real.
Yeah, Lewis adding a comment that certainly the improvement in the transplantation rate would have several really positive returns as well. So I think we've managed to fill in the hour. Sherry, do you want to do the closing comments?
Sure. Thank you, everyone, for joining us today. On behalf of the Coalition, we hope you've enjoyed the presentation and found the information beneficial. The webinar has been recorded and will be available on kidneysupportivecare.org in a few weeks. Please join us November 19th for our webinar on advanced care planning. And as you're leaving the webinar today, please be sure to fill out the evaluation when it pops up. Your feedback is so important. Thanks again for joining and have a great rest of your day.